what you rather have to look at is the patient in the beginning. So what does the patient bring to the table when we start the therapy? Is the comorbidities he or she has in the beginning, and for example, the fitness status of the patient in the beginning, can we start with this therapy in this patient, or should we move on to another one? So we know that, for example, BTKIs have a very specific spectrum with regards to cardiovascular toxicity. So we've heard some nice talks about the induction of hypertension in patients who are taking BTKIs. The bleeding risk is well known from now on, and the cardiovascular risks such as atrial fibrillation and ventricular arrhythmia are also well known. So if a patient has a plethora of cardiovascular disease, one would feel reluctant to start with the therapy in these patients and rather look at the other side of the table, which I mentioned before, which is time-limited therapy, for example, with Ven/Obi. And if you look at the other side of the table, you have a patient who has a impairment of their kidney function, but you have the danger of tumor lysis syndrome, or rather the extreme effectiveness of obinutuzumab or CD20 antibodies and venetoclax in the beginning, where you have to be really careful with the amount of destroyed cells and their detritus, which is basically released into the system. You want to have a good kidney function. So this is really what you want to look out for. The toxicities are known and are getting known even better with every advent, with every congress which we're having. We know more about these therapies, and we have to look at the patient in the beginning and then see what is the optimal therapy for this patient in the beginning.